طيب بسم الله الرحمن الرحيم. Thank you very much for our friends and colleagues. Professor Isa, President of Oman Society of Nephrology and Transplantation, our colleagues and friends in Oman. It was my pleasure visiting first time in Salalah, and I think that it will be my habit, inshallah, in the following years. It is not just a talk, it's a case of panel because it's our everyday practice looking for a safe line. I choose this topic as a safe line that saves life. So I will tackle what is the points of safety process gathering the line in the dialysis units. Our everyday practice, which is a safe line, can save life. It's exactly because of dysfunction, increased mortality, crepsy, thrombosis, embolizations, and more of the problem. So our discussion today is based not only on this talk, but also on your experiences at your center, just to make a universal approach or the guideline. We have a guideline here in Egypt looking for the best practice. And as usual, guideline is not a constitution, a guideline just to guide the practice into the optimum, which may differ between year and year or even month to month according to the literature and the randomized control trial. So what's our agenda today? We will have 6 points. And I think the most important is the 7th point, which is the open discussion from the field of excellencies and experts in Oman. We will have a few slides from the tips from the KIDUKI Guidelines 2019, which is the latest KIDUKI Guidelines for the vascular access. We have some challenges and myths, and these challenges, we have some solution and some on the landscape of solutions, and we'll have different kinds of catheter dysfunction. The big item in my talk will be toward the biofilm, crepsy, catheter lock solutions with different literatures. I know that there is a plethora of literature about some of the lock techniques, some with randomized control trials, very effective, and some still just a few slides on that, and finally coming to the conclusion. So what we have about the against the end-stage kidney disease patient life plan. We have 4 main points before starting the vascular access. If you choose an arteriovenous fistula or arteriovenous graft or a catheter, you have to first put the mind that this may be not the last line, it may be the only first line, and subsequent line is in demand. So what's called a vessel preservation plan, you have to preserve the vein or the vascular access before and after doing the vascular access for dialysis. Then you have to choose the creation plan according to many options, including in these options the patient preference. If the patient say, I wouldn't like to have an arteriovenous fistula, I need a CVC, for example, we have to obey the patient after discussing all the cons and pros for each item of the vascular access. Then we have to put in our mind that the complications plan, what I will do if a vascular access got a complications like thrombosis, infections, dysfunction. And finally, we have to decide the access succession plan on the following years on the journey of end-stage kidney disease and on dialysis. So this is the 4 points as a life plan, and it will come in one slide from the KIDUKI guidelines according to the plan. What is the definition? If we took together these points, for example, sometimes we are saying that catheter dysfunction, it's a very common terminology we are using. The patient has catheter dysfunction. But accordingly, what is the definition of a catheter dysfunction? It including that it's an inadequate dialysis provided that you don't need more time, more than 4 hours dialysis to achieve the adequacy. We can accept the KT over V or urea reduction ratio. Both of them, I hate to use it, of no marker of good dialysis. You can use beta 2 microglobulin reduction ratio of 70%, which seems to be more logic. But in general, when we define a catheter dysfunction, meaning that the inability to maintain the dialysis process by a good blood flow, which is sufficient to perform hemodialysis, adequacy, whatever the adequacy term, without significantly lengthening the treatment. You may reach KT over V 1.4, but the patient needs 4.5 hours or 5 hours to reach. This is typically a catheter dysfunction, whatever the cause, thrombosis, malfunction, kinking, whatever. Some points from the KDUKI guidelines highlighted here in 5 or 6 slides. Although it's 6 years ago, it's considered it's reasonable that in hemodialysis patient for whom a cuffed tunnel CVC is the most appropriate permanent dialysis access, there is no maximum time limit to CVC use. We cannot say the patient is for 6 months or 1 year or whatever. However, we have to use a regular evaluation, and it is a must to determine if the CVC remains the main appropriate dialysis access. You may shift the patient from CVC to another way according to the patient's scenarios. A second point of the guidelines saying that it's reasonable to assess or check the vascular access and surrounding area by physical examination prior to every cannulation, if fistula, or connection, if CVC, for a potential complication. So putting here in the QDK guidelines a pre-session evaluation of the vascular access as a must, although it's an expert opinion, but I think it's very easily to be implemented in the standard operating procedures. A third point for the QDK guidelines suggesting that TPA may be prophylactically used as a CVC locking solution once per week to help reduce CVC dysfunction. It is a conditional recommendations. We'll come later on this, on the RCTs done for this once weekly locking with urokinase. And it's still recommendation from KDUKI that intraluminal administration of thrombolytic agent in each CVC port, both direction, arterial and venous, to restore function of dysfunctional CVC due to thrombosis. So here is a two recommendation from KDUKI guideline. One is a preventive once weekly thrombolytic therapy, and the other recommendation is to use thrombolytic therapy for dysfunctional CVC in 2 steps guidelines. The third or fourth guideline suggesting that selective use of once weekly prophylactic CVC locking with recombinant can be considered in patients in need of long-term CVC who are at high risk of crepsy, especially in facilities with high crepsy. So again, another step of suggestion of the QDK guideline to use TPA here not only for thrombosis or dysfunction, but also for crepsy. It is moderate quality of evidence. And the use of alteplase or urokinase plus citrate 4% per limb for restoring intraluminal CVC blood flow in an occluded CVC. All of these points carrying both the preventive strategy and the management strategy before exchanging the catheter, as we know that exchanging the catheter or doing a new track will exhaust the vascular access sites of the patient. So we have to make sure that we have to preserve and the planning the further access to be reserved for severe cases. So this is the KDUKI 2019 selective use of once weekly prophylactic CVC locking with thrombolytic agent can be considered in those patients. And it is suggesting that low concentration of citrate. I used maybe 20 years ago citrate in a concentration of 40%, which was at that time the first plan for using citrate in patients on dialysis. Of course, has very too much drawbacks. One patient just arriving death because of leakage of high concentration of citrate. So nowadays we are talking about citrate on only 4% against 40% 20 years ago. There is inadequate evidence to support routine CVC surveillance culture. You don't need to do different cultures every time and time for a prophylaxis decision, but you have to do the culture only if you suspect crepsy, and will come later. There is no indication for the KDOQI guideline that selective use of specific prophylactic antibiotic lock can be considered, unless in two scenarios. When using antibiotic lock techniques, number one, the patient with frequent crepsy. Number two, if your unit is high incidence of crepsy above 3.5 per 1,000 patients, and cannot support the routine prophylactic use of antibiotic with very low supporting evidence. So what is the plan for the first part of my talk, which is the patient end-stage kidney disease life plan, first, then access needs, considering to map the patients not only on the current vascular access, but on the future vascular access. And the life plan considers the patients that medical and vascular access circumstances and the patient preferences. We have to ask the patient accordingly, what's your idea and what is pros and cons of each vascular access. Coming to many of the challenges, we cannot talk all the challenges. I know that there is much more than challenges in the CVC. However, we have mainly 5 main challenges. We will tackle 1 or 2 of these challenges today. What is the catheter tip design? Does it differ? What is the insertion site? Jacular, subclavian, femoral? What is the optimal CVC tip position for both temporarily and permanent catheter? And what is the best lock solution? We will focus on RCT on number 4. And when to change the catheter, it is another scenario and it needs another talk. So this is more of the challenges and the methods in CVC. Looking for the tip location, if we have non-tunnel catheter, which is rarely used in modern centers. However, it is in the superior vena cava atrial junction. However, if you are need in tunnel catheter, you have to do it more deeper into the right atrium, upper or mid atrium. We cannot use the non-tunnel catheter in the atrium because it's a firm and it can make a lot of damage. However, the flexible, soft material of the tunnel catheter should be in the mid-atrial position. What about CVC complications? We know some of them are of current clinical practice. We have mainly poor flow, very common, maybe due to just the positional. We have infection, exit site and non-exit site infections, crepsy, we have thrombosis, and we have the devil of the catheter, which is the fibrin sheath. No treatment is available just to remove the fibrin sheath. So we have different methods and evidence. We have to change our practice from non-tunnel to tunnel catheter for patients need dialysis more than 2 weeks. With a systemic review that tunneled are associated with lower rates of crepsy because tunneled are made with soft polymer with a soft flexible tip and are less prone to mechanical complications such as vessel perforation as compared with the more rigid non-tunneled catheter. What about the poor flow? Both CVC dysfunction and infection can occur early or late from the time of insertion. However, poor flow in the early phase mean usually insertion problem, kinking, or malposition. It may occur due to mechanical factors like kink and malposition, or obstruction intraluminal by thrombosis, or obstruction extraluminal by fibrin sheath. And so, catheter dysfunction, we have different mechanisms. Thrombosis, central venous stenosis due to trauma, and central venous thrombosis, both of them. Stenosis may be due to prolonged use and stenosis of the vein. However, presence of thrombosis, I saw many patients with central vein thrombosis that may arrest during starting of dialysis because of detached thrombus and migration to the pulmonary. We have mixed thrombotic and infection, and keeping here in mind that usually poor function or mechanical issue can predispose for clepsy and infection, yes, because poor flow or thrombosis, you may have to use different techniques and different manipulations, and all of these can propose. Even stagnation can induce. We have different risk factors for catheter-related thrombosis. Maybe patient-related risk factors like hypercoagulable state, malignancy, thrombophilia, elderly, obesity, immobility and hospitalization, frequent previous thrombosis, thrombocytosis, and others. And maybe catheter-related risk factor, which is minimal for that, unless it is non-cuffed, it's more prone for thrombosis. Insertion site may determine, and site of insertion left to right, left more prone for thrombosis due to stagnation and multiple insertion attempts. The tip location typically in the proximal to superior vena cava has more catheter-related thrombosis than atriocaval, than more on the right atrium. Presence of fibrin sheath and clepsy also predispose for catheter-related thrombosis. And here is the typical picture of superior vena cava thrombosis with dilatation of the veins, non-pulsating jugular veins, and usually the patients develop huge puffiness of the face. All the face will be puffy. And this is one of the quizzes. If you have a patient, and you may respond on that on the chat, this is one of the patients who had non-functional catheter and you decide to remove the catheter. After that, after removal of the catheter, you find that this on the radiology. What do you think about this photo? Sorry, Ahmed, I'm in the middle of my talk. Please stop sharing. It's okay. And this is one of the radiological finding before moving the patient to another vascular access. You find this after removing the tunnel catheter. What do you think about that? What's the differential diagnosis? As our colleagues saying that one of them that it's a fibrin sheath and another say that it's a remnant from the removed catheter. Yes, exactly. Both are positioning correct. However, if you look in deeper part, you can find that this part has no hollow air inside, and it is a must after removing the tunnel catheter to check the catheter it's completely removed or not. And if you can find here inside an air, this is definitely a remaining catheter, but here is a solid, no air inside, so this is a fibrin sheath. And this is a malfunction. What's your diagnosis? In this part, as the arrow saying that it's a big part of the right atrial thrombosis, which may extend later on. And the echo finding, bedside, you can determine the right atrial thrombosis like that. It's out of our scope how to manage, but this is one of the complications. So coming to what's a biofilm and eclipsy. This is the part 4 of my talk. Biofilm can develop at any time from starting of the catheter insertion. At any time biofilm can develop. We have catheter-related infections, maybe exit site, which is less than 2 centimeters surrounding the catheter exit site. If above, we can have tunnel infections, which is inflammation, extending beyond the 2 centimeter from the exit site. And here you need to change the catheter and to do another tunnel, new tunnel. And you have the originally believed dangerous one, which is a crepsy. And from crepsy, bacteremia, we can have embolic distant infection. So we have different catheter-related infections, exit site, tunnel, crepsy, or hematogenous embolic infection. And this is typically what's happened in the biofilm. If you find that this is the steps of biofilm, which can happen even after few hours from insertion, with formation of bacterial, and the bacterial grow up to make a huge layer on the wall of the catheter. This layer, part of the bacteria, will resist the antibiotic approaching the bacteria on the side. So the best management of biofilm is to prevent by locking solution and antiseptic technique. However, presence of biofilm may resist the treatment by antibiotics and can induce serious complications. The big part today is the catheter lock solution. I have a dilemma of catheter lock solution. We have Torlock, Torlidine, we have Edita, sometimes saying that it's can use bicarbonate, and some saying that it's ethanols and other methylene blue. So we have many of the literatures about the catheter lock. What have been proven efficacy according to the RCT, I will highlight. So I looked away at prophylaxis and the management of catheter-related thrombosis in hemodialysis depend on our maintenance protocol for the catheter patency. From literatures, we have antibiotic lock, we have ethanol, we have torlidine containing lock, we have heparin, we have Edita, and I said that we have ethanol, and even in literature bicarbonate and others saying that more by methylene blue. Antibiotics have demonstrated efficacy, but there is risk of developing antimicrobial resistance and cost. Ethanol can induce structural CVC damage and risk of catheter occlusion. Torlidine containing lock solution is the most effective. To my practice, I use it for more than around 10 years. It's very effective. Heparin, which is common in developing countries, underdeveloped countries, in malpractice, and some suggestion of the Edita. I don't know why Edita are using, but I researched it for the publications, very scanty publication on the Edita. For the CDC infection control, saying that it's a category 1B, don't administer systemic antimicrobial prophylaxis routinely or during use of intravascular catheter to prevent catheter colonization or crepsy. It's saying clear. And categorization of two of the CDC use prophylactic antimicrobial lock solution in patients with long-term catheter, again, like clinical guideline, who have a history of multiple crepsy, and if the unit has a higher percent of crepsy, more than 3.5 per thousand, although the optimal maximum adherence. To myself, I don't use antibiotic lock solutions also for more than 5 or 7 years. And this is coming from the Clinical Guidelines 2019 from the intraluminal strategies, effect of antibiotic, antimicrobial, other solutions on crepsy. The summary of randomized control trial, we have 3 moderate quality of evidence. We have cefotax, gentamicin. We have here weekly TPA with a moderate quality of evidence. However, EDTA, ethanol, hypertonic saline, all of these are very low quality of evidence and very low randomized control trial inputs in that. So we'll focus on the others like torlidine and TPA29. The antibiotic-based lock solution, typically we need very high concentrations of an antibiotic, 100 to 1000 times in minimum inhibitory concentration, are combined with anticoagulant to reduce the risk of thrombosis or catheter occlusion. It has many of challenges for this high concentration. The dwell time for the lock varies depending on the specific antimicrobial from 30 minutes to 24 hours. This very high concentration of antibiotic lock can be leaked from the catheter and can induce antibiotic resistance microbe. And usually we don't use that except in the 2 scenarios by the clinical guidelines for the frequent crepsy alone, and the unit is not perfect. These challenges of antibiotic lock technique including antimicrobial resistance, potentiality of systemic toxicity, formation of biofilm, associated resistance of pathogens. So antibiotic lock technique, although it's also very costly to use antibiotic and withdraw the vial after few used. For the EDTA lock, I've tried to find any. In the multi-center study, they reduce the colonization. However, reduction rate of crepsy was not significant and was associated with a higher thrombolysis rate use. So EDTA is already not in our recommendations because it does not decrease significantly crepsy and increase the cost by thrombolysis rate use. For the heparin, who are still using heparin, I stopped using heparin maybe 10 years ago because heparin can induce leak, and from the leak, heparin can significantly increase the bleeding time, can induce heat, yes. Heparin has no antibacterial effect, and the massive bleeding and hematocrit value were significantly decreased. Even in some literature, they are saying that heparin promoted the formation of staph biofilm and made the patient prone to crepsy. So it's vanished now to lock the catheter with heparin, although still some centers, and this is in publications 20 years ago. And bacteria associated with heparin stimulating biofilm have a high level of resistance to even vancomycin. And this is the 3 points against using of heparin as log solution. Coming to Tarlac, torlidine, and urokinase, it is installed in the catheter, and this is all these photos are coming from the internet. It's available for free, and I will show you in just 2 minutes the technique of installations, just to have an SOP for nurses with a very slow installation, not more than 1 milli per second. And this is coming from the internet available. I can share just to educate the nurses and patients about that. You can formulate all these steps in the video into an SOP written. Most of these steps are in our clinical practice of the nursing, quality control, infection control. However, the last step of installation needing more attention. I will jump here for the installation for the video. I will share this video. And you can use some idea about that in the flushing into pushing technique, flushing just to dissolve any remnants inside. So there is in the literatures, in the publication, in meta-analysis across 16 trial, more than 1,000 patients, urokinase significantly prevent catheter malfunction, restore blood flow significantly. The incidence of CREPSI in the treated group was lower against others. For the cost, yes, it costs more session by session, but on the long term cost, it is less because you don't need too much angiography, vascular access remapping, and removal of the catheter. And most importantly, you are exhausting the exit site. We are using here in Egypt 2+1 protocol in most of the center for the long days of the hemodialysis weekend by urokinase installation. Another trial, it's published maybe 7 years ago on 148 patients. After urokinase treatment, blood flow and the pre-pump pressure improved because the vascular access flow improved. It's more usually in severely dysfunction catheter resulted in significantly larger improvement. Both on the short and the prolonged administration, locks were efficient in restoring the blood flow and subsequently adequacy of hemodialysis. We know that inadequate dialysis can prone the patient for anemia, can more of the infections and another, maybe CKD, MBD, hyperphosphatemia, malnutrition, a lot of impacts of inadequate dialysis simply by vascular access dysfunction. And this is for the mechanism. It can dissolve fibrinogen and reduce the continuous formation of thrombosis. And in several studies that concluded that the success rate of local catheter-guided urokinase in alleviating catheter obstruction was approaching 95%. So it's accordingly, this is very effective to save the line and to save the life as well. This is the cumulative success rate of thrombolysis in one studies 6 years ago. And this is after the first intervention, 90% of patients had regained back the success of the line, reaching 97% after the second intervention and approaching 100% more than two interventions. So we have using that once a week to help reduce CVC dysfunction, and it's a key recommendation as we discussed before. For the torlodine, it's well known and it's one of the best solution to my knowledge and to my use. I use it always in any tunnel catheter. It has an antibacterial, broad spectrum activity, both gram-positive, negative, high reactivity with key bacterial components, minimizing bacterial resistance. In contrast to conventional antibiotic, its antimicrobial activity, including MRSA, and also coagulase negative staph. It also exhibits antifungal properties. From my experiences using that, it was very effective all through probably 10 years up till now. It's including in our Egyptian hemodialysis guideline to frequently use in patients with that. Many studies, I will show you that with torlidine plus 4% citrate, 500 international unit heparin per dialysis, and the urokinase we are using once per week. Here is the sum of the literatures. Too many literature and randomized control trial. That's why the clinical guidelines saying that the thrombolytic therapy and others are important. But here, many of these randomized control trials develop after the clinical guidelines. Over a period of more than 15,000 catheter day, in controlling that against episode, catheter dysfunction significantly lower in torlidine group with lower rescue for the alteplase. However, it's more in other way. So torlidine is more cost saving versus citrate alone because for the torlidine it prevents also antimicrobial. Citrate 4% cannot work as an antimicrobial. It's need higher concentration, 30 or 40%. So combining citrate with torlidine giving the maximum protection for both thrombolysis and also. And this is the graph typically showing the days between different use of log solution, citrate alone or torlidine. And it's coming from, I think it's one of the USA publications, and it's published in the CJSNs, and they concluded that in more than approaching 800 patients for the heparin versus torlidine heparin solutions, the crepsy percent is really higher in heparin. It's approaching 8% against torlidine, only 2%. And this is the systemic catheter lock solution for observational studies for 57 patients. And this is published in coming from Barcelona. I will highlight this trial. Although small number, 57 patients, however, it's given that a more effective way for 5 years. So it's prolonged studies for 57, 32 patients and others for that. And this is heparin arm also again for the torlidine arm and heparin arm. And this is coming from the randomized double-blind active control phase 3 trial in the CJSNs published 2023. Of no doubt, we stopped use heparin for a long time. Again, another study this year, 2025, for the EDITA antimicrobial and comparison of torlidine. On that, torlidine is more effective than 4% EDITA acid in eradicating gram-positive and gram-negative microorganisms. I never used EDITA for catheter lock. And this is a study 4 years ago, BMC nephrology, and a retrospective observational multicenter study that for the CVC due to infection or catheter removal and the access for different lock solution, torlidine, high concentration citrate and low concentration citrate. For sure, high concentration citrate is not usable. Only citrate 4% is not enough for antimicrobial. So the study showing significantly lower rate of CVC removal due to infection or malfunction or combined for the torlidine citrate arm against other citrate alone high concentration or low concentration. And this is the graphic presentation, removal due to infection or removal due to obstruction due to patency problem, highlighting the graph that torlidine is much better. So the overall incidence rate of proving catheter-related bloodstream infection, very low, 0.37 for torlidine, 0.89 for high concentration citrate, and the same finding for small citrate concentration. And it appears that CVC-related bloodstream infection in patients with torlidine paste lock were less often caused by also Staph aureus and slightly more often by gram-negative pathogen, which is يعني أرحم بكتير من طبعا presence of Staph aureus may be in need of sepsis and removal of the catheter. In vivo, it has been shown that torlidine citrate heparin catheter lock solution are associated with a decreased risk for staph bloodstream infection. In one center, studying that 239 replacing heparin with torlidine citrate as catheter lock was associated with statistically significant 56% reduction in staph bloodstream infection rates. Again, in another studies, more than for patients with preeclampsia, the study population's episodes was 2.4 per 1,000. Torlidine citrate in this study against heparin showing that it's nil, approaching 0 per 1,000. Plus, of course, the infection control program. And this is coming from Shams University, the Torlock heparin, and we approve here in this study, it may be 5 or 6 years ago, that dialysis adequacy and the blood flow rate significantly better outcome for urea reduction ratio, meaning that patent line and catheter bloodstream infection, the incidence in heparin group versus Torlock was much better for the Torlock, and this is my colleagues. We shared that with Magdi Sharawi and the other colleagues in our center. It's 2021 and it's published in the ERA editor. So this is one of these additional anticoagulation has no significant in delay sheath formation. This is just one slide denoting that sheath formation is important to prevent, not to treat, as fibrin sheath, valvular-like obstruction will need definitely catheter plus or minus sheathing removal. So intervention to prevent and treat CVC dysfunction, including taking care of the insertion and maintenance and urokinase use, torlidine, fibrin sheath disruption if happen, you can try. Finally, catheter exchange and insertion on the same site to preserve additional site for further plan, and this is more importantly that to preserve the vascular access of the patient. So in conclusion, heparin lock solution should not be used. It should completely eliminate the risk of hit and promote biofilm formations. Urokinase and its derivative can effectively prevent catheter dysfunction or thrombosis. There is no proof that citrate alone, even at high concentration, is beneficial in comparison with heparin regarding crepsy. In theory, low molecular weight heparin is not suitable as a lock solution. We never used. Strict control of crepsy is a preventive measure. Using toluidine citrate heparin solution seems to be the most effective way in clinical practice and the most discussed in the literatures. Recurrent crepsy in selected patients, especially if the unit experiences high rate of crepsy, may require antibiotic lock technique plus systemic antibiotics. Citrate alone heparin or EDTA are more inferior to toluidine citrate heparin solution. And thank you very much. This talk was originally coming from the Crit Dial and the Nephro fellowship that we started yesterday, a new fellowship with new fellows. And I thank all of the fellows who are graduated this time coming from Oman. We have Ahmed Atris and more. And new fellows from Oman, I think 3 or 4 from Oman, had just joined yesterday. Thank you, Mr. Chairman and Professor Isa and my colleagues. I hope this is informative and will open the discussion of that time. Thank you very much.
Thank you very much, Dr. Hisham. Thank you. Jazakallah khair. Excellent lecture. Well informative. I don't know whether Ahmed Saeed is ready to share his slide and start presenting.
Assalamu alaikum, Dr. Isa. I am ready and thanks for you and Dr. Hisham for this informative lecture. I would like to build from Dr. Hisham based talk the plan of our work in Suhar Hospital. Actually, we based in KDUKI guidelines, as Dr. Hisham said, that recommendation of lock solution in high incidence units with high incidence of catheter-related infection is suggested. Also, we take in our consideration cost effectiveness and also safety. So during our work in prevention of catheter-related infection, we have selected the most safe and cost-effective lock that to decrease the incidence of catheter-related bloodstream infection, which is a major comorbid we are facing. So I would like to today to show or present my work, which has been done through a multidisciplinary approach by nephrology and the clinical pharmacy and infectious disease team, which has been published as an abstract in ISN. Today, our study is effect of tunneled hemodialysis catheter antimicrobial lock solution in prevention of catheter-related bloodstream infection and its impact on reduction of treatment cost. As a background, central venous catheters remain a common form of vascular access for patients with chronic hemodialysis, despite recommendation by several national and international guidelines to minimize their usage as much as possible. Widespread application of central venous catheter exposes patient to an enhanced risk of catheter-related infection, which includes catheter-related bloodstream infection and exit site infection. The incidence of catheter-related infection varies per dialysis unit, site of insertion, type of catheter inserted, and adequacy of catheter care. And the catheter-related infection results from migration of skin organisms along the catheter into the bloodstream or contamination and colonization of catheter lumens. Prevention strategies are directed at decreasing growth and or adherence of pathogens to the catheter hub and surface. As we said, Dr. Hisham explained to us, biofilm constitute a permanent source of bacteremia, as well as being a key factor favoring bacterial resistance. And as we see here, the biofilm, one of the source of resistance bacteremia and also catheter-related bacterial systemic infection. So guidelines still, those suggested intraluminal antimicrobial lock solution, but still there is controversy which is the most suitable lock. I informed that Torlidine, we choose it as the most safe and least side effects, and also comparing cost effective. One of antimicrobial lock solution is a derivative of amino acid taurine, has broad spectrum antibacterial activities against gram-positive and gram-negative bacteria and fungi. By the binding of its hydroxymethyl group to cell walls and proteins and cytotoxins. It is also non-toxic and non-antibiotic lock alternative that does not cause bacterial resistance and has no adverse effect even if it leaks into circulation. The addition of heparin to toluidine citrate has been shown to strengthen its efficiency regarding catheter patency. Therefore, toluidine can prevent formation of biofilm in the catheter and reduce catheter-related bloodstream infection. So our study design, as I informed, based on in need of a preventive strategy to decrease the incidence of catheter-related infection, use the most safe and least side effects, and also cost effective. So we study the toluidine-based lock solution in prevention of catheter-related bloodstream infection. So our study has been done on 100 patients in Sohar Hospital hemodialysis unit through dialyzing through tunneled hemodialysis catheter. It has been divided, the duration was 1 year, divided in first 6 months, measuring the incidence of catheter-related infection while patient using heparin. And next 6 months, we measure incidence of catheter-related infection while patient on toluidine citrate and heparin lock. We compared between the both groups in incidence of infection, incidence of hospital admission and ICU admission, and incidence of catheter-related complication and incidence of mortality and the treatment cost, as I mentioned, which is one of the factors that we choose the lock solution. All inclusion criteria that the patients on regular dialysis with tunneled catheter, and the exclusion criteria, we excluded patients with difficult vascular access and patients with tunneled hemodialysis catheter that the only function vascular access, patient with poor flow from the catheter, and patient with active infection, and any patient who displayed allergic reaction or from citrate or toluidine. So our result actually was very significant in the terms of comparing both groups, group A patient on heparin lock and group B patient with toluidine lock. There was significant statistical significant difference, 68% incidence of catheter-related infection, comparing on 12%. and the average incidence of catheter-related per month, it was 11%, allowed 11%, and the toluidine group was 2%, with high relative risk between the two groups and the highly significant statistical difference. Also, in comparison between the two groups regarding the incidence of hospital admission, it was very significant. We got in group A 37 ward admissions with total days 552 days, and ICU or ICUW admissions, it was 5 admissions and total days 53. In comparison with group B, with patient on toluidine, ward admission was 2 with total days 15 days. This showed significant statistical difference of ward admissions. As a consequence, also we comparing the cost of both group, it showed estimated total cost of ward admission 6,896, ICU admission 4,752 Real Omani, in comparison of toluidine based 456 Real Omani only. The comparison between the two groups regarding the incidence of catheter-related infection complication also was significant. Infective endocarditis 3-0, infection-induced thrombosis 8-0, total catheter-related complication 11-0, and catheter loss 13-1. Mortality incidence, it was 4, which is very significant, but it showed low statistical significance due to low number of patients. So we concluded also that toluidine-based look is have high statistical significance reduction of catheter bloodstream infection, hospital admission with consequent reduction of total treatment cost, and it is cost effective. It showed also clinical reduction of incidence of catheter-related bloodstream infection, complication, and mortality. My concern regarding that it is not in the guidelines, KDIGO guidelines as toluidine, that it has been studied in low number of patients. So they are not able to put toluidine as a guidelines, that baseline guideline for all patients. So I think if we toluidine has been or examined or used on over a higher scale of patients, it may be one of the guidelines that would will help in reducing catheter-related systemic infection. So thanks for your audience, and I'm ready for any questions.
Thank you, Ahmed, and I leave the floor for Dr. Isa to handle the question and answer. And I think we can open the discussion by hearing from the expert as well. It's yours, Professor Isa.
Thank you very much, Dr. Hisham. In fact, I put a couple of questions before. In Oman, probably we are one of the few countries around the world where we utilize catheter per population the highest.
Yes, I noticed that 100 patients in center, it's more than 15% if you are...
By far more, because generally speaking, we have probably less than 10% people who enter dialysis have a AV fistula. So majority of our patients start presenting as acutely with their end-stage kidney disease, and we go through the various steps. Usually start with femoral catheter for a few days, then JVC, then a BERM catheter, and BERM catheter sometimes stays up to a year, and we have certain patients, and possibly the people from Suhar Ibrahim Said, or even Ahmed Saeed can tell you about a patient called Hassan, who has the catheter, I think, for 8 or 10 years.
Yes, for sure, Dr. Isa. We are following him.
Yes, and we had 5 cases who developed catheter-related thrombosis clot, which they had to undergo open cardiac surgery to remove that sort of thrombus, huge thrombus.
Thrombosis.
So this is very unheard of. Yeah. So I don't know whether the magnitude of I'm sure it's less by far in Egypt because the preemptive sort of AV fistula rate is much, much better than us. But I would like to hear your opinion in this sort of scenario and situation which we are having here.
Actually, not so much. We published in the era maybe 7 years ago on 22,000 patients in Egypt, the registry. I presented that in the era. Actually, yes, the CKD vascular access program is lacking in many countries, including even Egypt. However, by definition, if the patient started by temporarily catheter for emergency or permanent catheter, it should be within 3 months to shift to arteriovenous fistula or arteriovenous graft. So the incidence of initiating dialysis with a catheter is high, still high, maybe reaching 80%. But on the if we have the prevalent patient, not the incidence one, after 3 months, the reverse happen and usually put the patient on the vascular access arteriovenous fistula program, and less than 20% are still on catheter. And interchangeable because sometimes you have arteriovenous fistula complications, hematomas, infection. We shifted to temporarily catheter and go on. But definitely we don't have such a huge percent. I think it's aligned with USA catheter use, which is still very high, Professor Isa. May you have a plan for that for the vascular access surgeon to be in hand. I don't know how to solve it, but I think we have to decide that all incident dialysis patients should be going for AV fistula. Professor Isa, are muted.
Yes. Yeah, I think, in fact, I'm asking all our colleagues across Oman because the problem, the tension always come to the capital. And in fact, there's a need to improve the health service in Oman to the preemptive AV fistula should be a priority, like a gold standard. And even if we have to involve the actual private practice, I think there's some improvement in certain centers, but still in other centers we have a major issues where catheter is the main stream of utilization for hemodialysis.
بروف عيسى السلام عليكم.
السلام أهلا يا أحمد.
تفضل
الله
يا أحمد.
يخليك. Thank you for Prof. Hisham and Dr. Ahmed Saeed. Regarding the solve of this problem starting to be يعني improved in Oman after pre-dialysis clinic. يعني now we have many pre-dialysis clinic follow up the patient in CKD stage 4 and 5 and يعني we reach in our clinic in SIB dialysis center to about 60 to 70% of patient preemptive fistula. فاي ثينك ان يعني more pre-dialysis clinic I think in يعني in the future may solve يعني part or important part of this problem. The other point ان we Prof. عيسى لو كان remember our study in patient with recurrent BCAS infection and كان في about 4 patient can usually admitted maybe 3 or 4 times per year in the tertiary hospital due to caster-related infection recurrent, and we use antibiotic lock for this patient. And after that, from this study, maybe 3 years back or 4 years back, zero infection for this patient.
Yes,
Thank you.
Thank you, Ahmed. I think your center is one of the best in Oman regarding preemptive AV fistula, or as Hisham to be done within a few weeks post dialysis.
Yes, I
But in
think
other centers, still we have an issues. What do you think, Dr. Hisham?
I think yes, it's a national wise. I think as you are chairman of the Oman Society of Nephrology, you need to make a flyer for that and to be distributed. You need more education of nephrologists and the vascular access surgeon should be available in everywhere. Just to have, if you don't reach the patients in the pre-dialysis CKD, sometimes patients escaping from dialysis and it's worldwide problem. But if you cannot reach the pre-dialysis arteriovenous fistula, so you have to concentrate about the 3 months initiating dialysis. يعني محتاجة شغل كتير يا دكتور عيسى. آه، من حاجات كتير، ورق وفلايرز وإديوكيشن للنفرولوجيست وللعيان كمان للبيشنت.
Yes, indeed, I do agree, Dr. Hisham. جزاك الله خير. يا أحمد, شوف there any question يا أحمد عفيس
حاضر.
to be.
chat not open with me. I don't know why.
أنا شايف الشات أهو.
اتفضل.
السلام عليكم. ويلكم. أو أنت فايبرين شيث. أيمن قائد أنني أيمن is asking about fibrin sheath. This is the answer of the quiz. Yes. Remnant part of the caster calcification. Professor Isa is asking already. Professor Isa Fadi. Hello Fadi. ازيك يا فادي؟
دكتور هشام، ازي حضرتك؟
ازيك يا
شرفنا
حبيبي؟
النهارده يا بيه.
الله
ازي حضرتك؟
يخليك.
اهلا وسهلا. ربنا يخليك يا بيه.
الله يخليك يا شادي. Should catalog solution be risk stratified, particularly in patients with recurrent thrombosis and or infection, or should universal 2+1 Torlok protocol be used for all dialysis patients? It depends on the center policy. I think من الليتريتشر ومن بعض السنترز عندنا 2+1 Torlok protocol the most effective. And the most cost effectively. يعني انا عرضت one study coming from Barcelona and other studies. الريت اوف اكسشينج اوف كاثر due to dysfunction كان عالي جدا في الناس اللي ما بتستخدمش 2+1 بروتوكول. To my experiences المشكله في not only the cost، هي الاناتومي والافيلابيلتي اوف فاسكولار اكسس. يعني عيان بيخلص الجاجولار وبيخش على الفيمورال وستيل بيحصل له ثرومبوسس، بعد كده انت ما عندكش غير ترانس لامبر ولا ايه. فاي ثينك it's better to be universal 2+1 Torlok protocol long interdialysis period اللي هو بالنسبه لنا بنعمل له لوك. وده بعض السنترز بس بتستخدمه روتينلي. For high risk patients you can start with high risk patient، الناس اللي جالها قبل كده different caster or ما عندهمش اساسا vascular access available. ده last seems يعني vascular access is a must. خلاص ده ما عندكش اختيارات، لازم تحافظ على الاكسس ده.
تمام يا بيه. طب ايه راي حضرتك في النيو بيشنتس؟ يعني النيو بيشنتس لسه مركبين تانل فينس كاثيتر جديد، هل احنا نديهم تورلوك 3 سيشنز من غير يوروكاينيز، ولا برضه 2+1 بروتوكول؟
اتس بيتر
which do you
طبعا
think؟
2+1. يعني ده يعني من الليتريتشرز واللي مكتوب انك انت بتحافظ على الفاسكولار اكسس زي ما اتفقنا في البلان. البلان
اوكي.
انك انت مش تو انسيرت بس، انت تو انسيرت وتحافظ عليه، لان الافيلابيلتي اوف اذر فاسكولار اكسس ممكن يبقى صعب مع اللونج جيرني بتاعت الدياليس. فاذا
اوكي.
كان فيزبل، 2+1 طبعا از ذا بيست. سكند اوبشن انك انت هتستخدم تورلوك بس الون. مفيش اوبشنز تانية، يعني هيبرين بقى وايديتا وهايبرتونيك سالاين وميثيلين بلو والكلام ده يعني قتل بعد.
ليس كواليتي ولو ايفيدنس كمان.
لا خالص. بالنسبه للانتي بايوتيك كلوك زي ما الدكتور احمد عتريس قال، هم محطوطين في 2 سيناريو بس. سيناريو ان عيان بيجي له كريبس كتير،
ايوه.
تمام، وان الوحده سيئه وانت مش عارف تعمل حاجه. لكن I don't use antibiotic clock تكنيك خالص خالص يعني.
ايوه. ايوه احنا ريرلي، يعني ريرلي اولموست زيرو برضه.
فاي
بس
ثينك
احنا
تو
دايما احنا
اوبشنز.
عندنا التورلوك من زمان، بس التورلوك يوروكاينيز لسه ستارتنج ان عمان، يا دوبك جاست ستارتنج. بس احنا وي ار يوزنج تورلوك هيب، يعني يعني از روتين في الروتين يوز، فعشان كده احنا جاست بلاننج بروتوكول فور 2+1 ريسنتلي يعني.
ما انت عندك 2 سيناريو، يا اما هتستخدم فور سي في سي ثرومبوزيس ديسفانكشن، هتستخدم مره 2 3 وزي ما عرضت كده ممكن يجيب نتائج لغايه 100%، لكن ده رياكتيف مش برو اكتيف. الافضل
اوكي
منه البرو اكتيف 2 بلس 1، لان على اللونج
اوكي
تيرم كوست هو بيقلل الكوست يعني. احمد طبعا سعيد جايب ريزلتس كبيره جدا. الفرق في الكوست 90% او
يس
مور، فيري هاي كوست هوسبيتاليزيشن وانتي بايوتيك ريزيستنس. على الرغم ان هو نون statistical significant الديث 4 اجينست زيرو، انا شايف ان 4 دول فيري significant لاهله. فاهم قصدي ايه؟
مم.
يعني it is not just a number يعني. فاهم قصدي؟ لو انا
انا
يس
المورتاليتي 4 to 0، انا بالنسبه لي لو هي الارقام statistically non significant، انا بشوف 4 families and 4 lives had been. وعشان كده اخترت العنوان بتاع النهارده سيف لاين سيفز لايف يعني.
اي ريدكشن في المورتاليتي حتى لو مش
لو اقدر
statistically
اقول
significant to
اضيف
be
حاجه يا
considered.
دكتور هشام.
اه طبعا.
احنا الهدف بتاع الاستادي بتاعنا ان احنا نهايلايت how much is this castrated bloodstream infection one of the major complications we are facing. يعني in Sohar
طبعا
we are facing it so much, and we want just to highlight that it is not like one ampoule which is more cost to heparin. It is one ampoule more cost to life. For this,
طبعا.
we designed this study, and we choose the most or most safe, because we يعني go through other anti-lock which got we know about side effect. One of them is antibiotic lock with resistance. So Torlodine, our Torlock, it got actually good results and low instance. I have برضو another point. We go through the KIDUK guidelines, and we have our study was based in KIDUK guidelines. But while we are designing it, we know that it is a lock solution has low suggestion or not much suggested. But it is different in two situations with high incidence of castrate infection units. And also these studies has studied on low number of patients. For that, Kiduki did not put it recommendation or recommendation A. So my also aim of my study that we can use lock solution. One of them is Torlock, that if we use it in a higher scale of patients, it may be a base guidelines worldwide. For this,
صح.
this is why our design, our study, we performed it for three main reasons. That we highlight that castrated bloodstream infection, one of the major complications we are facing. Second things, in the safety and using a lock, it is cost effective, because we got a citation, a lot of citations that you increase the cost of the session or for whatever regarding heparin. But we highlighted it that regarding cost of investigation and antibiotic and admissions and ICU admissions, it is very low regarding heparin. And as a recommendation also, that if we use this lock in higher scale of patients, it may be a guidelines worldwide. For this, we are
Correct.
doing our
Correct.
study.
And 6 years ago, I put the Egyptian guidelines. It was 200 page for the hemodialysis, including the vascular access. And I wrote on that 2019 that we have to use it because for the efficacy and safety profile. فأنا كتبتها already في الجايد لاينز، مستنيين الكيدوكي جايد لاينز يطلعوها.
We changed it. And
طبعا.
this actually we shared this study in ISN, and we discussed it with other moderators about the same, يعني that it is low scale. For this, it is not recommended a recommendation of Kiduki يعني.
شكرا يا احمد جزيلا.
شكرا دكتور هشام، شرفت بحضرتك.
الله يخليك يا حبيبي.
I
ابراهيم
think
سالم.
Dr.
دكتور هيثم
Hamid
اتفضل.
Gilani has a comment, similar situation, if he's still around.
دكتور حامد.
Yeah, Assalamu alaikum, sir. Thank you for
Wow.
giving me a chance. Excellent presentation, the most common problem which we are all facing. In fact, we did a retrospective trial in around 90 patients, compared Torolock in around 47, versus heparin, and we found that the catheter-related infection CRBSI was very less in Toroloc, around 0.4 over 1,000 catheter days compared to around 2 in the heparin group. So it was significant, although the population size, this sample size was small. And then we published this data in HJKD. So we are planning to increase the sample size to see the effect of Toroloc on the wider sample size. So I think Toroloc is coming up as compared to the heparin in these patients. So it's a good observation that we are getting similar data across the other Gulf countries.
But you don't use urokinase still.
No, sir, we don't use urokinase.
So
We
extend
use
your study with urokinase for dysfunction and epilepsy as well. 2+1 protocol.
such recently enter النوبان اللي هو تورولوك بلس يوروكاينيز.
Yes, we need to build up our data. يعني,
Yeah.
I think it's a time to have additional. Toroloc is basic خلاص يعني, of no doubt يعني. We have to build up our data كمان من Toroloc urokinase. You can choose patients more at risk, poor flow, frequent crepses, and so يعني crepsy. So يعني we need to test it as well, although the literature is strong.
Okay. So, sorry, is there any comparison of Toroloc versus urokinase? Any large studies which compares between the two, or just
Toroloc urokinase and Toroloc without urokinase, you mean that?
Yes.
Yes, in that there is one study I can share later on for the cost effectiveness and the dysfunction. It's coming from Barcelona for 5 years, 57 patients. And I think this is one insightful one. The duration was 1,000 days with urokinase against around almost 300 and something for Torlodine alone. So it gives a very potential positive results, and highlighted in one slide. I can share later on the PDF file. I can send to Ahmed Atris this talk in a PDF file, and you can find one slide of them highlighting that. Yes, there is one slide on that.
Thank you very much. Jazakallah.
I think Dr. Ibrahim Sayyid كمان he has a comment he want to say. Ibrahim.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام دكتور إبراهيم.
Thank you, Dr. Hisham. You are welcomed us. شكرا دكتور عيسى, Dr. Ahmed Said. Just quickly, we have an issue at Sohar Hospital since long time, as we are considered the reference unit covering the whole governorate, who are receiving all patients once they have fever and shivering during dialysis. They are referring all patients to us from the peripheral units. But that's why. Another issue, Dr. Isa, we have mixed dialysis unit. We are dialyzing at the same time, same place, same persons, inpatient with outpatients. Unfortunate to say, we have an endemic virulent organism at our hospitals. A lot of issues, a question mark that you highlight, Dr. Isa, about the quality of the catheter itself. From time to time, they are going to change the catheter from company to company. We don't know what to do. We have an issue regarding vascular surgery, regarding the survival rate of their fistula, whatever, preemptive or just failure rate, used, not used. We have a lot of issues. The same for the patient themselves. We have both extremes of age, multimorbid, comorbids, hypercoagulable, a lot of issues we have as we are considered at critical dialysis unit. Also, as I mentioned, multimorbidity or comorbidities, plus an endemic infection. So that's why we have held more group meeting, auditing. We have a lot of formation of guidance, advices, action plan, but unfortunately, we are suffering that issues. So that's why we have dilemma, especially you have some patients, they have long standing catheter. We have one patient or 3, maybe more than 9 years, they're leading through the catheters. We have a high frequency rate of catheter bacterial stream by infection for majority of patients that are admitting 4 or 5 times per year. We have many patients immunosuppressed, immunocompromised. I think that's why inclusion criteria or exclusion criteria is very important. How proper select the patient who can get benefit from the prophylactic therapy. It is still prophylactic therapy. It is not direct therapy for infection. But that's why I need to highlight about this issue, inshallah.
Yes, thank you, Dr. Ibrahim. I know that quite well. Unfortunately, there's few stakeholders who are not quite interested in the general well-being rather than trying to cut costs. And when you try to cut costs and jeopardize quality, things get out of control. And unfortunately, pharmaceutical supply at the ministry at large have failed really to discuss various issues of requirement with the end user. And there's a pitfalls or possibly misuse and abuse of power at these sort of levels. But hopefully, inshallah, we'll try to improve those. I don't know what Dr. Hisham has any further insight to this problem.
Yes, I think it's a national program, Professor Isa, and it's a basics could be carried by Oman Society of Nephrology statements, clear statements, uh, because many of the centers has no why the rationale. I think ده اللي احنا عملناه في الجمعية. We can getting the guidelines and directly towards the centers and our recommendations. ممكن بعد كده نعمل لها auditing ونعمل نشوف how much of the guidelines are applied in the units, making it difficult ان center to center يبقى عندها challenges. يعني عمان دولة كبيرة مترامية الأطراف ومراكز كتير في كل حتة. I think يعني حضرتك مع البورت مع الوحدات كلها ان هو كان carry a suitable SOP clearly defined وديستريبيوتد. ده يعني متهيألي ده هيبقى أسلم طريقة، أسلم حاجة يا دكتور عيسى.
Inshallah, I think we shall do that in the coming future. Within the coming 1 to 3 months, we shall issue such a warning letter, in fact, to the higher authority. We'll see how it is. I think there's another one more comment by Imad Hamad, if he's still around.
السلام عليكم دكتور عيسى.
ورحمة الله وبركاته يا عماد، تفضل.
علاء عيسى. علاء
تفضل يا
السلام
علاء.
عليكم هشام، ازي حضرتك؟
أهلا يا علاء، ازيك؟
الله يسلمك. كنا عايزين بس ناخد رأي حضرتك في كام نقطة كده، يعني
اتفضل.
حضرتك اللي متميز في الموضوع ده. يعني احنا بنعتبر ان البلاد اكسس از لايف لاين زي ما حضرتك قلت. يعني اور ايم في كير ان هو بروتكت فروم مال فانكشنال. يعني هو تراي برولونج ذا لايف سبان او ذا لايف اوف ذا ايزر سنترال فينس كاستر كافد اور نون كافد اور الاي في اف. للاسف الاي في اف عندنا اقل بكتير من يعني المفروض الاي في اف هي تكون 70% و30% كاستر، بس
المفروض
احيانا بيبقى العكس.
80% 85% كمان يا علاء، في يعني المفروض 85%.
لكن للاسف في الاولد ايج عندنا والديابيتك والحاجه مخليه الكاستر هي اللي اكتر من 60% بالنسبه للمرضى مع مشاكلها. يعني فكنا الاول حضرتك بنستعمل اللي هو الهيبارين لوك غصب عننا لان كان التارولوك مش متوفر، فكانت الريت نفسها بتاعت المان فانكشنال كتيره. يعني يمكن بعد ما بدانا نستعمل التارولوك الريت بدات تقل فعلا، يعني وبقى البرولونج لايف بتاعت الكاستر نفسها. يعني فحضرتك كان في ترند اللي هو يوز اور لو انتي كواجولان او نو انتي كواجولان يوز، يعني على اساس يبقى الدايلايزر نفسه مع الانتي كواجولان بتاعه على اساس يوفر الوقت والتايم وافويد اليوز اوف انتي كواجولان. حتى كان في
انت قصدك هيبرين كوتد داياليسيس.
ايوه هيبرين جرافتد دايلايزر اللي هو بتاع الايفودايال او غيره. يعني
اتس كومبليتلي فيلير. يعني داياليسيس ممبرين. اصل انا اشتغلت على ده في الار ان دي مع المانيا في القصه دي من 20 25 سنه. اتس كومبليتلي فيلير ابروتش طبعا، لان هيبرين عشان تبقى كوتد على الداياليسيس ممبرين محتاجه بوندنج معين. وبعدين زي ما انت عارف الهيبرين ما بيشتغلش سيرفيس، ده الهيبرين بيشتغل سيستميك. يعني ما هوش هيشتغل لوكالي على الدايلايزر. لا ده هيبقى عشان كده الهيبرين كوتد داياليسيس ممبرين فيلد طبعا.
هو كان الفكره فيه ان هو يقلل السيستميك افكت بتاع الانتي كواجولانت نفسها
الريزلتس
على
كانت الريزلتس ما كانتش سوبيريور عن اي حاجه تاني. انت عندك الدايرسيس ممبرينز، الستيم ستيرلايزيشن انا دايما اعمل عليه شغل كتير، وفعلا الستيم ستيرلايزيشن one of the best تكنيك فور ستيرلايزيشن هيوميديتي اوف ذا ممبرينز، بيقلل كتير جدا الانتي كواجريشن ريكوايرمنت. لكن هيبرين جرافتد ممبرين هي قصه قديمه وبقالها سنين، لكن فيلد يعني مبقاش فيه حد بيفكر فيها خالص.
كان في برضه اللي هو الفيتامين اي انجريتد لاينز برضه اند
يس
دايزر.
فيتامين اي ديفيشنسي، فيتامين اي امبلانتد، وكان عليه
ايوه
برضه ستاديز. ولما سالوني رايك ايه الكلام ده ممكن 15 years ago، قلت لهم why to coat the dialyzer with vitamin E. I can supplement the patient with vitamin E if required. It's no need. So يعني الدياليسيس membranes ما بقاش يروح ناحيه الكوتنج، بقى راح يروح ناحيه المور هيدروفيليك. مور هيدروفيليك ممبرينز معناها ان في ستراكشر هيدروفيليك. انا اشتغلت على القصه دي كتير وعملت في حوالي 100 انوفيشنز فيه. ودلوقتي برضو بيشتغلوا الاف ام سي على الكورال مور هيدروفيليك ممبرينز، لكنك انت تركب حاجه على الممبرين يعني اتس اوبسوليت، فيتامين اي او هيبرين يعني.
شكرا جزيلا لحضرتك دكتور هشام، ربنا يبارك في
اهلا
حضرتك فينا يا رب.
اهلا بيك دايما.
شكرا
تسلم
شكرا
دكتور.
دكتور هشام. Anyone has any further comment or question? All right, then I would like to thank Dr. Hisham again for his great contribution and really making our meeting quite alive and progressive as always.
Thank you very
And
much Dr. Isa. It's my
last
pleasure
minute,
دايما.
I'll leave it to Dr. Ahmed Atris to close the meeting. Ahmed,
حاضر.
the floor is yours.
جزاكم الله خير بي. سبحانك اللهم وبحمدك نشهد ان لا اله الا انت نستغفرك ونتوب اليك. بسم الله الرحمن الرحيم. والعصر ان الانسان لفي خسر الا الذين امنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. تصبحون على خير جميعا ان شاء الله.
شكرا جزيلا وتصبحوا على خير ونشوفكم على خير دايما ان شاء الله. وجود
شكرا
لك في
بروف.
المؤتمر بتاع الصحارى ان شاء الله يا احمد، ان شاء الله وبقيه التيم ان
الله
شاء الله.
يبارك فيك.
ان شاء الله نشوفكم على خير دايما.
شكرا جدا.
السلام عليكم.
السلام عليكم.
ان شاء الله.